This session this morning. My name is Karen Peters. I work with UNODC, based at the Regional Office for Southeast Asia and the Pacific in Bangkok. We have a very exciting lineup of speakers this morning. The session will start now and end by 12 noon, and then we can get a break for lunch. We have 3 speakers from 3 different parts of the world. Allow me to just introduce them before inviting our first speaker up on stage. The first one is Mr. Chase Holleman from US drug policy, covering US drug policy subject matter. And he's going to give us an overview of the US federal policy and lived experience in teaching harm reduction in the United States. Then we have Dr. Fran Calvo from the University of Girona, who's going to cover the Spanish policy on drugs, on harm reduction, the experiences and teaching of university students. Last but not least, we have Dr. Martin Agwogie, who is the founder and executive director of the Global Initiative on Substance Abuse. And Dr. Martin Agwogie will speak about harm reduction in university-based addiction studies in Africa. Our speakers will have 15 minutes, and I will kindly ask them to try and keep as much as possible to the time. I will remind you gently when the time is nearing completion, simply because we would love to have wholesome, enriched conversations around the topic of harm reduction. I know that there is, and at the past have been, some contention within drug demand reduction and harm reduction. But we are hoping to see how this tension is resolved through the teaching and the experiences of these experts in their regions of the world. So without further ado, and I think I'm the one that has to, oh wow, okay. No? Yes? Who puts the presentation up? Oh, great. Okay, perfect. Thank you. Great, so I don't have to do that, perfect. Yes, so please let me introduce Chase. Mr. Chase Holleman has an LCSW and LCAS and is a licensed clinical social worker, a licensed clinical addiction specialist, and a subject matter expert on United States drug policy. His work has spanned substance use prevention, treatment, recovery, and harm reduction at the local, state, and national level. Chase began working on harm reduction as a syringe service volunteer with the North Carolina Harm Reduction Coalition. Several years later, as the director of Guilford County Solutions to the Opioid Problem and assistant professor in the Department of Social Work at UNC Greensboro, he co-founded a harm reduction services program that doubled as a clinical training site for social work students. Today, Chase is especially grateful that harm reduction enabled him to live through multiple overdoses himself, and knows that he is alive today because he had access to harm reduction services, quality treatment, and mutual aid from his peers. Anyone, anywhere should have access to harm reduction, prevention, treatment, and recovery support services, and Chase enjoys working to create those pathways. The floor is yours, Chase.
Thank you so much. Can everyone hear me?
Yes.
Yes? Okay, great. Thank you for the kind introduction. As was mentioned, my name is Chase Holleman. I'm from North Carolina State in the United States. And I'm a person with lived experience, which I always try and mention. It's part of my why, and I think it's important for the work that I do personally. Currently, I do work for the United States Department of Health and Human Services, and I want to be clear that I'm here as myself today and not a representative of them in anything I say today, or my own views and not reflective of the United States government. So I'm going to go ahead and dive in the interest of time. So first, I'm going to breeze through a bunch of slides to set a little bit of context. And the first thing is it's impossible to talk about drug policy in the United States without talking about racism and the war on drugs and incarceration. This mic is falling. You can see on, you can see here between 1970 and I think here ending at 2010, there's a 500% increase in the carceral population in the United States. 1 out of 5 of those is a drug offense currently. You can also see that there is disproportionate representation, especially of Black Americans in the carceral system currently, as well as American Indians, Hispanic, Spanish-speaking populations in the United States. And this is super important. 1970 began the war on drugs, and I talk about all of this because I heard the word tension earlier, and there is an existing and ongoing tension, many tensions in the United States that span race and also drug policy as we shift more towards harm reduction and public health, because we still do have a system of interdiction. The effects of the war on drugs are still felt by many communities in the United States. People are still put into cages for using drugs, and it's important to talk about. It's hard to do that and also say that we care about people who use drugs. So around the early 1990s, late 1980s, there was a growing HIV/AIDS epidemic in the United States. A group of very brave individuals, a lot of them LGBTQ+, and people who use drugs got together to save their own lives because no one else would. They started in response to racist drug policy, the war on drugs, and government inaction against the HIV/AIDS epidemic. And it started with a couple folks on 2 corners of the United States setting up shop on the sidewalk and passing out needles. So currently there is an overdose crisis happening in the United States, largely driven by illicitly manufactured fentanyl. You can see in this graph here the very large jump in that dotted line in 2015. That is synthetic opioids. You can see the death per 100,000 jump from between 2 and 4 all the way up to 10. To frame that another way, between May of 2021 and May of 2022, drug overdose deaths increased again, and they accounted for over 108,022 lives lost, breaking the 100,000 mark for the 2nd year in a row. Provisional data suggests that we will break the 100,000 mark for the 3rd year in a row. In response to this, we've seen a slight shift in U.S. drug policy towards harm reduction. The Biden-Harris administration named harm reduction as one of its 4 key pillars of its overdose prevention strategy in October of 2021. This is important. Harm reduction was not explicitly supported by name before that time by the Department of Health and Human Services. This has resulted in a number of resources being shifted that way. I've just got some examples of them here. A grant program, a framework defining harm reduction. I heard some conversation around the room about what the definition of harm reduction is and to whom. I think there's a lot of discussion about that. And then some other things happening. So naloxone, the drug that reverses an opioid overdose, was announced to be made, one singular brand was announced to be made over the counter in its nasal formulation in March of this year. Just at the end of July of this year, they approved a second over-the-counter naloxone nasal spray product. This is to increase accessibility to people who use drugs so that they can have it for themselves and people they care about to reverse overdoses. And then I have a congressional act here. Before this act was passed this year, prescribers had to have a special waiver to prescribe buprenorphine to treat people with opioid use disorder. A lot of people didn't do that because it was just another barrier between them and doing that. So to increase accessibility and uptake of prescriptions being prescribed, something else to look out for is the growth of overdose prevention centers, also known as safe consumption or safe injection sites. In the United States, the first one tried to open in 2019 in Philadelphia called Safe House. It is still currently under litigation after the United States prosecuted it before they could open. That is ongoing, and the United States would have no comment on that until it is resolved. Meanwhile, Rhode Island, as a state, has passed a law to have an overdose prevention center, and it's not opened. And then in New York City, an organization called On Point, which is a conglomerate of some of those folks I spoke about earlier in the late 1980s, who saved each other's life because it was the right thing to do, they opened one without asking anyone. And they would say it's because if they asked, they would say no. They opened well over a year ago, and they are still operating. So they are operating, and nothing has happened to them yet. So I think a lot of people are wondering what that means for the United States. Drug checking is growing, especially with illicitly manufactured fentanyl and now xylazine. Very recently, $26 billion was released in settlement from a number of large drug manufacturers after they were found culpable in overprescribing and misrepresenting the safety profile of opioid prescription pills. That's another tension. So a largely unregulated health industry. So naloxone, the nasal spray that was first made over the counter earlier this year, retails for $150 US a kit. In the thousands of people I've served who are at risk for overdose, I do not know a single one of them who has ever walked into a pharmacy and spent $150 on naloxone. So to shift gears real quick, zooming in on the community that I come from, which is Guilford County. It's in North Carolina, a state on the eastern seaboard of the United States, a population of around 541,000 people. What this looked like was rather dramatic. 2012, EMS responded to less than 3 overdoses a month. There were some underground harm reduction services at the time. In April 2014, 2 years later, in one 24-hour period, EMS responded to 25 overdoses. 5 of those were deaths, which is a huge increase, obviously. Literally overnight, fentanyl hits. There were 413 administrations that year. We see just a little bit of efforts here. By 2016, 587 administrations. So this means number of times that emergency medical services administered naloxone to a patient who had presumably overdosed. By 2017, that number had jumped up to 1,023, and it has hovered around there and increased slightly for the last 6 years since then. So extremely felt in the community that I'm from. I'm gonna try not to get emotional because it includes a lot of people I care about. So that spurred the start of an organization I co-founded called GISA, or Guilford County Solutions to the Opioid Problem. As was mentioned earlier, it is a harm reduction services program that doubles as a clinical training site for social work students, largely social work students. We have some public health students as well who operate under my supervision. I'm a licensed counselor. I have experience providing inpatient and outpatient treatment, as well as harm reduction community-based services. It is unique in that it's a partnership between the university, the county, mostly emergency medical services, but also the 3 law enforcement agencies that serve our county, allowing us to go into the jails. And between community and lived experience, as was mentioned, I'm alive today because of harm reduction, and many of the people who serve on our team are people who use drugs or people who formerly use drugs with lived experience, and that has been important in our ability to build credibility with the community and meet thousands of people that we have since then, for many of whom we are their only medical touch point. The reason the university is involved is for academic validation and evaluation. The Department of Social Work, as mentioned, a large team of students does the services. We have a collegiate recovery program at the university that is huge. There are over 100 students in it currently, who are all people in recovery and attend the university and bond over that, have a shared community over that. It's been an incubator. It had its own overhead, county relationships, and a referral pool for those at very high risk. So people who have overdosed already are at very high risk to overdose again. So we'd be referred people by EMS who have overdosed if they consented to a release of information. And then access to vehicles, purchase ordering of syringes, other things. Provide services like motivational interviewing, harm reduction, I'll talk about what that looks like, counseling, peer support, etc. Post-overdose response team I just mentioned, so that's following up with people after EMS has revived them within 1 day, offering them syringe services, naloxone that they can use to reverse overdoses, or treatment if that is something that they're interested in full case management and counseling. Street outreach component, mostly in motel parking lots. We work with law enforcement and emergency services to heat map where overdose hotspots are at the time. So like each week we'll receive a report, we'll see that this motel on the side of town had a number of overdoses. We'll go respond, set up shop there, and meet folks and help them however we can. Justice Involved program where we go into the jails that briefly mentioned, and these are all essentially different referral sources or different locations that we provide the same set of services. In North Carolina, people who are released from jail are at 40 times risk to overdose in the first 2 weeks following release, which is huge. That can be generalized to people in abstinence-based treatment or detox who lose their tolerance. Providing low-barrier medication for opioid use disorder, largely buprenorphine, so having providers who come into the community with us into homeless encampments and meet these people. I mentioned we are the only medical touch point for a number of people. Since 2018, over 30 graduate students and 15 undergraduate students were able to do their social work student practicum with us. Around 50% of them have lived experience of substance use and or recovery, and who have served over 3,000 unique individuals in a 540,000 person county since 2017. Since July 2022, that's looked like 2,552 contacts with people, 154 linkages to treatment, meaning someone started treatment, started care, a lot of them buprenorphine with our program, 5,700 naloxone kits distributed, and 1,000 overdose reversals reported by our participants. So that means a participant of our program used naloxone to save someone's life, or vice versa. And that was reported to us. To put that in perspective, that is nearly the same number that emergency services reversed, and this is largely underreported because we hear about it when they come see us next week and we ask. 343,000 syringes distributed, 257,000 back. So the educational component is really important. We have a very intensive orientation. It begins with a process circle that students sit around. We have an outside person, a faculty within the department who does restorative justice in these circles as part of his research and how he actualizes that research. And we repeat that throughout the practicum to build community or resolve conflict if needed. Overdose prevention training, crisis intervention, a lot of radical ethics training. CBT, motivational interviewing is hugely important. Role playing for how to build rapport with people as we're working with folks who, again, as their only medical touch point, they do not like talking to other people, and for good reason. They often report being abused and mistreated by healthcare providers in the community. Give them a program history of overview, take them through the budget, talk about projects that they can do, data collection, proper handling, and evaluation training. And there's a lot of ongoing stuff. So licensed supervisor, that historically was me, would always be on call as people are out. They would always go out as a group. Weekly supervision individually and weekly group supervision, as well as a weekly operational team meeting. Students would often do their own led projects. That's looked like women's support groups. It's looked like new grant programs. It's looked like new locations. The sky is really the limit for a lot of the students, and they've done some really impressive things as such and been supported to do so. The ongoing process circles, a lot of processing of stuff people see. Opportunity for professional development and training. We had a group of students give a presentation at our statewide Addiction Professionals Conference, and opportunities for advocacy and community organizing, networking, and building partnerships has been really important. Some main tensions I just wanted to cover quickly is, again, the racism and criminalization stigma that exists and discrimination in our community. I talked about that with the healthcare providers. Although around 50% of students are in recovery, a lot of them are in a very specific abstinence-based recovery and have ideas and attitudes and beliefs towards people who still use drugs that may not be true or may not be helpful for them. So a lot of this is processing every week and breaking that down, taking a very hard look at how we treat people and think of people and really leaning into those things is very important, breaking that down. And again, that just the stigma reduction, looking at that, processing things. And yeah, I know that we're running out of time, but that is very, love this program. Happy to answer any questions.
Thank you very, very much, Chase. That was really insightful, and you did very well with timekeeping, so I'm also appreciative of that. We probably have a million questions. I'm going to ask you to please keep them till the end, and hopefully we'll have also a little bit more of a discussion than just a Q&A session. So next, I'm going to invite, or have already invited, Dr. Fran Calvo. Dr. Calvo holds a bachelor's degree in social education, a bachelor's degree in psychopedagogy, and a bachelor's degree in psychology, a master's degree in health psychology, a master's degree in social and community work, and a PhD in psychology. He has worked for over 20 years as a specialized social educator in the field of drug addiction. During this time, he has been responsible for the implementation of harm reduction programs in the province of Girona, one of the 4 provinces of the Catalonia region of Spain. He has led intervention teams in open environments within the same region and has experience as a director of therapeutic centers specialized in drug addiction treatment. Since 2015, he has been an associate professor at the University of Girona, and started in 2022. He has dedicated himself entirely to research and university teaching at the Universitat de Girona. He is a member of the management team for the master's program in drug dependencies at the university. Fran has published over 50 scientific articles in international impact journals and has participated in more than 100 communications and presentations at various international conferences, including this one. His research topics include drug addiction and extreme social exclusion, particularly residential exclusion and homelessness. Welcome, Fran.
Thank you very much, Karen. Hello and good morning. First of all, I would like to thank the organizers for their invitation to participate in this symposium on behalf of the management team of the master's degree in drug dependence at the University of Barcelona. I would also like to thank all of you for your presence here in this seminar on the organization and inclusion of prevention and harm reduction in specialized academic training. During the next 15 minutes, maybe I will need 2 minutes more, Karen, sorry. I will present the paper Harm Reduction in Spanish Universities, the Experience of Barcelona, which will deal with what harm reduction is in my country, in Spain, taking the case of Barcelona as an example. Afterwards, I will explain the experience of the master's degree of the University of Barcelona on how this topic was introduced in a specialized academic training from its beginnings until today, making a brief historical overview. Here is Dr. Xavier Ferrer, the director of the master. If you want to participate, as you know, you are invited. So first of all, I think that it's worth recalling that there are different definitions of harm reduction. One widely accepted definition is one proposed by Marlatt early in the 18th. This definition said that harm reduction are those programs, services, actions, institutions whose aim is to minimize the harmful impact of drug use. As you all know, the phenomenon of drug use and drug dependence is a very complex phenomenon. Up to now, it has been considered that the optimal organization of a territory in the management of drug use associated problems at drug dependence usually involves 4 main areas: policies, substance control policies, supply reduction legislation on this issue at international, national, local, municipal, regional, etc. levels. It includes social and health policies at territorial and community level, as well as clinical, social, spiritual, healthcare, etc. Prevention, and at its different levels, universal, selective, and integrated prevention, whose objectives may vary, and which range from trying to reduce demand, delaying the age of onset of consumption, preventing risk and harm associated with consumption. The treatment or treatment recovery of the drug addictions when an addiction already exists, the actions in the different phases that the person goes through: outpatient, residential, hospital, individual, family, group, pharmacological, psychological, social, community, etc., with the aim of achieving complete recovery. often based on abstinence from drug of abuse. And finally, harm reduction, following the definition I have already given you. Therefore, when we talk about harm reduction, it should be noted that harm reduction is far from being the only approach, as it's combined with a strong offer of abstinence-oriented treatment and prevention to avoid early use, dependence, and all forms of problematic use. The boundaries of these four acts are blurred. In other words, they are interrelated and ever overlap at some points. For example, if we subscribe the trans-theoretical theories of change or motivational interviewing for drug dependence treatment, it is common for people in the initial stage of the process, people who are still using the drugs that motivate the treatment, to receive advice aimed at minimizing the harm associated with drug use. Harm reduction counseling can therefore be received within a treatment phase or service. Another example is that treatment services, should they be needed in the future, but the consumption rooms and the needle exchange program significantly reduce the number of syringes in the street as a result of this of the street use. Sorry. Finally, the peer-to-peer significantly reduce the mortality rate associated with heroin and cocaine injection. It must be said that despite the proven evidence for such programs, their deployment is threatened by moral, political, and social issues. As we already know, although alcohol, tobacco, and cannabis use is more common and in certain environments more normalized than cocaine and heroin use, and can even cause more community and individual harms. There is a great stigma attached to this type of cocaine and heroin users that hinders their adequate treatment according to the specific evidence. So turning now to the second part of the presentation, it's our responsibility as university training addiction specialists to provide them with a full spectrum of information and competencies to perform their professional task. This obviously includes harm reduction. In our view, harm reduction should be seen as a part of our prevention activities. Prevention means preventing the occurrence of an unwanted event which is considered harmful. Use drugs may facilitate many harmful and unwanted events to occur, especially when that use is repeated, among them death, overdose, social exclusion, dependence, family troubles, accidents, crime, illnesses, etc. Dependence itself has a special position into this list, as it's a harm of itself and at the same time many further facilitate the occurrence or many other harms. It's important to highlight the difficulties we may face when teaching students about harm reduction issues. Firstly, prior attitudes, values, and beliefs related to their own consideration of drugs, their personal experience, and of which are highly morally charged. Another issue is the feeling that harm reduction is not a success as the person continues to use drugs and to suffer from many of the associated problems, for example, dependence. On the other hand, among our students, who are medical doctors, psychologists, social workers, nurses, etc., we find some people, a lot of people, who have suffered from addiction themselves or their family members. In these cases, to decrease sense of guiltiness on themselves or loved ones, all the evil is attributed to the substance. No compromise with evil is then possible, so harm reduction approach may be a danger to their potential functional constructs. Professionals on the health and social sector like to cure, to save, to fight, to eradicate. Also, politicians and media like this commit an absolute world. But often the true best available option is just to improve, to keep alive, to achieve the best possible outcomes, to decrease harms, and to alleviate. In this environment, how can we do to improve harm reduction training? First of all, it's necessary to change the minds of the learners. change minds in the sense that there are no absolute truth or a single easy solution. The first approach that many students have been subjected to has often been black or white, yes or not, good or bad, desirable or unacceptable, praised or zero tolerance. We propose a learning environment based on open, careful and respectful discussion to try to accept that people in their freedom and choice may be unable to unwilling to stop using drugs. This includes, the program of the master includes 50 hours of face-to-face harm reduction training, as well as visits to specialized harm reduction services or programs like that, methadone programs, syringe exchange, family violence prevention programs, overdose prevention, accident prevention, drug testing and information at night parties, harm reduction within the prison, etc. Finally, their placement within the second year, 300 hours minimum, maybe full-time in the harm reduction program or facility according to their choice. They can choose their placement, and a lot of students want to go to the harm reduction services. Their master thesis could also deal with harm reduction, so they choose a subject within. In our experience, the harm reduction module was included in the curriculum from 1989 onwards. At the beginning, it received a lot of hard criticisms for not being sufficiently anti-drugs. It should be noted that almost all of our former critics are now strong supporters. We are in favor of tackling the issue, even if it's a conflictual one, respecting the diversity. I would like to take the opportunity here today to recall that in the end, many of the health problems we have today are due to bad habits, and that in the end, all this of bad habits have to do with the inherent difficulty of human beings to manage their cravings and pleasures. In the end, harm reduction is aligned with other well-integrated health actions, such as dealing with people who eat inadequately, don't do exercise, drugly, risky sports, etc. I would like to thank you again for your attention and your invitation to the organization. Here you have the email, my email, the email of Xavier Ferrer, and the email address of the master degree. Thank you very much for listening to me.
Thank you very much, Dr. Calvo. Also very insightful. Wow, I'm really enjoying the presentations today. Next up, another insightful presentation, and from the continent of Africa, we have Dr. Martin Agwogie. Dr. Agwogie is the founder, executive director of the Global Initiative on Substance Abuse, a non-governmental organization promoting the development of addiction programs in higher institutions of learning in Africa, in addition to its primary objectives. He is the national president of ISUP, the Nigeria chapter, and a board member of the board of directors of ISUP Global. Dr. Agwogie is also the assistant coordinator of International Consortium of Universities for Drug Demand Reduction in Africa, and a global trainer in demand reduction, an expert contributor of the UNODC WHO International Standards on Drug Use Prevention, and the UNODC guiding documents on the role of law enforcement officers in drug use prevention in the school settings. He is an assistant professor, Department of Psychology, Virginia Commonwealth University in the United States, a Fulbright scholar, the Hubert Humphrey Fellow of Virginia Commonwealth University in the United States, and a distinguished Hubert Humphrey Fellow, an alumnus of the prestigious Harvard Kennedy School of Executive Education within the US, and a fellow of the National Institute of Drug Abuse, NIDA, yes. He is a member of the Prevention Expert Advisory Group of the US INL, and holds a PhD in psychology from Ahmadu Bello University, Zaria in Nigeria. Among other academic and professional qualifications, he is a certified addiction professional and author of many books on substance use prevention, management, and policy, with many academic publications. He has over 26 years of experience in drug control, part of which was with the National Drug
Programs. There are over 12,000 universities in Africa. And these universities cut across the 5 regions in Africa, and addiction programs are offered in 8 universities across 3 regions. West Africa, we have Nigeria, Eastern Africa, we have Kenya, and Southern Africa, that is South Africa precisely, we have 4 universities there offering addiction programs. This is the outlook of addiction programs in Africa. The total number of universities, 8, with 10 different programs across different levels. The teaching of harm reduction in universities in Africa. What I did in preparation for this training was to search for publications that have identified the universities that offers addiction programs in Africa, and also use key informant interviews. Through these 3 universities, we identified each from the 3 countries that have universities that offers addiction studies. From these 3 universities, the harm reduction course content were reviewed. From there, I picked University of Cape Town as a model of the teaching of harm reduction in Africa for this presentation. So this is my summary after reviewing the course content, the harm reduction course content of University of Cape Town. Of course, the course content defines harm reduction, talks about the myths and facts about harm reduction, justifications for harm reduction, the different approaches to harm reduction, and of course, the need to develop a collaborative alliance in harm reduction. I like this sketch that talks about the continuum of care from excess, moderation to abstinence. So any step towards a decrease in substance use is a step in the right direction. So the cost content, the harm reduction cost content in UCT is in line with the concept of Logan and colleagues as defined here, also in line with the 6 principles of harm reduction as identified and defined by Hawk and colleagues. Well, this is a very long extract that from the work of Logan and colleagues, but for the sake of building a foundation for this presentation, the next few slides, I'll just go through what I extract from this publication. It says, consideration of harm reduction therapy does not mean a therapist doesn't see any consequences or potential problems with a client's decisions and use of a substance. Harm reduction means a therapist can see the client's situation in more than black and white, all or nothing terms. A reduction in harm may or may not be sufficient for a client, but at least it is a starting point to build rapport, encourage change, and support efficacy. Harm reduction therapy means not withholding services when a client can't or won't meet our treatment outcome ideas. Harm reduction therapy means we meet the client where they are and help them along for as far as they will let us. So I will be discussing the principles of harm reduction by Hawk and colleagues as identified here in the next few slides. So I will not bother to look at the definitions and approaches, but how these are treated or taught in UCT. For example, the content has provision for non-stigmatization of people who use drugs, teach about non-stigmatization of people who use drugs, and knowing that some users do not wish to stop and why they don't want to stop. They're not having preconceived ideas about patients or clients. Also teaches about respect for human rights. The second principle, which is pragmatism, the course content there teaches about risk factors for drug use, also provide accurate and unbiased information about drugs, the different levels in drug use, associated consequences at each level for each drug, and of course, different patterns of use. The course content also has a range of support for persons who use drugs, from economic to behavioral and so on. It also teaches drug use and remaining relevant to families and at work. The third principle, according to Hawk and colleagues, is individualism. And how is this taught in UCT? Diversity of persons who use drugs, development of individual drug use, harm minimization strategies, and of course, harm treatment goals, or individual treatment goals. Then principle number 4, autonomy. This talks about collaboration. It is not all about what the therapist feels, but it is what the therapist and the client or patient sees and how they view it. And of course, reconciling differences on common grounds. Then the fifth principle, incrementalism. This talks about come as you are approach, learning safer drug using practices. All of these are part of the course content of University of Cape Town as far as harm reduction is concerned. The expectations to the next level of harm reduction. Then of course teaches about how to take care of self and starting a reduction plan for different substances, including alcohol, cannabis, opioids, and so on. And of course, celebrating progress at each step. Then the sixth and the last principle here is accountability without termination. So the course content provides that there is the need to take responsibility among patients or clients now for care for self using substances regardless of which of the substances they use or their substance use status. Then of course that reuptake of substance use or the substance use is part of recovery and not a sign of failure. So all of these are part of the content, the harm reduction content in UCT. So summing this up, I see all of this and more as part of the goals of harm reduction in UCT course content. So besides reviewing the course content, the harm reduction course content in University of Cape Town, I also reviewed the drug policies in the 3 countries where addiction programs are being offered. That is Nigeria, Kenya, and South Africa. And I would say that harm reduction is captured in the current drug policy document of these 3 countries. But what it is now in the current drug policy document was not the case in the previous drug policy document, which means there is a shift, drug control policies in Africa moving from punitive to public health approach. For example, in the last edition of the drug policy document in South Africa, that was the 2013-2017, it defines harm reduction and with a caveat, localized version of harm reduction. If I may just quote it quickly here the way it is, it says the commonly recognized strategies applied in the NDMP 2013 to 2017 are demand reduction, supply reduction, and a localized version of harm reduction. So, well, we have heard so much of that, different definitions of harm reduction and so on. And part of the localized version of harm reduction in that policy document is that harm reduction or limiting or ameliorating the damage caused to individuals or communities who have already succumbed to the temptation of substances. That was more like the definition and the localized version of harm reduction in that policy document. But the current document now adapts the WHO definition of harm reduction. I may not have the time to go through it exactly the way it is here, which means there is a shift from what it was to the present realities of public health approach to drug control. So Nigeria, for example, the drug law in Nigeria criminalizes drug use. But the current harm reduction policy document provides for full implementation of harm reduction services. And the drug law that criminalizes drug use is still, has not been amended, is still an active law, but the policy document, which is the National Drug Control Master Plan, made provision for harm reduction. So somehow it may look like a conflict, but it also means that Nigerian drug policy has moved from where it was before to a different dimension in line with public health approach. And let me also quickly add that any opportunity from now, I want to believe that that part of the law will be amended to reflect the present drug policy document. We also have a good understanding of how legislative procedures could be, it would take so much time and so on. Then harm reduction policy in Kenya. Harm reduction is part of the 4 pillars of the drug control policy in Kenya. It actually made provision for different stakeholders as part of their roles in implementing harm reduction policy. For example, the central government, the National Drug Control Agency, Ministry of Health, civil society, prison services. So the drug policy document made provisions, specifying their different roles. So as I begin to round off, what are the views of experts about harm reduction in Africa? Some of the views are that stakeholders are not making maximum utilization of the provisions of harm reduction in the drug control policies. In other words, it is no longer much of a policy issue, but it is that the stakeholders are not maximizing the content of the drug policy as far as harm reduction is concerned. Then that some also have the views that the primary focus of treatment interventions still remain abstinence. And of course that there is a knowledge gap in the teaching of addiction studies in Africa. So some of these views are also understandable, considering the fact that Africa countries are gradually moving from the punitive approach to drug control to more of public health approach. So it will definitely take time for some of these policies, to evolve and reflect in practice. So in conclusion, I would say that for effective teaching of harm reduction in higher institutions of learning, it is important that the national drug policy of the country accommodates harm reduction as a component of drug use intervention strategies. And of course, there's the need to improve knowledge about drug use disorders, and the need for a change in perception about people who use drugs and harm reduction practice generally. So let me quickly acknowledge my colleagues who, in one way or the other, contributed to the development of this presentation. Professor Michael Ezewan, Dr. Beatrice Katungu, okay, maybe not here, then Rihanna, and of course, Fergus. So thank you, everyone, and these are my references. I'm happy to respond to your questions. Thank you once again.
Thank you very, very much, Dr. Agwogie. Another insightful presentation. I believe the conversations are going to be very, very rich. I'm going to change things up a little bit and hopefully have a makeshift panel here in the front and see if we can have questions and a little bit of a discussion between the panelists as well on the topics that were presented. Please can I invite Chase and Dr. Agwogie and Dr. Calvo up to the front. Here we go. Great. I'm very sure there are a lot of questions or comments or reflections on what was presented. So I'm going to now open the floor to you, the audience. If you have any questions for our panel or reflections. Yes, okay.
Yeah. Yeah, thank you for the three presenters for the presentation. It's really give me insight. I'm interested to the comment of maybe from Fran or anybody, any other presenters here about the experience on teaching harm reduction in the institution. I'm from AIDS Research Center at Majaya University in Indonesia, and we did the same thing. Similar. We have the experience with teaching harm reduction, making it into 4 days course for magister students on psychology. And at first, we developed the materials based on some of the reference that we have, like the training for harm reduction, giving them the introduction about the harm reduction, basic principles, and also the list of type of services. But later on, what I realized really make change for the participants. This is my experience, and I want to understand about your experience as well. One of the important for on the teaching or education for harm reduction to make people change from their framework or their mind frame about looking at drugs issues is when they realize the big picture of the problems. So it's not only about the addiction or it's not only about melanggar. It's against the regulation or it's illegal activities. But when the people, the students or the audience understand this is the impact when we have certain regulation or policy which is not supportive, and then the impact is beside the physical, but also about the social issues, and then that's really affect the people, and then, oh yeah, this is important, and then they can accept it. This is my experience, and I wonder about your experience, because in Indonesia we have maybe more than 20 years now the official response from the government, but the harm reduction has been discussed like in 2001 when I started working on this, but it's never been officially accepted in the documents, and maybe like and in the UN convention as well. It's 2016. It's never been stated as the harm reduction, but everything in it has included harm reduction. And in Indonesia we have pretty much similar, but a little bit harsh, I think, because like the needle syringe program has not been officially from the government, from the Narcotic Bureau, has been mentioned a little bit, reducing the harms, but maybe for other department like Ministry of Health, they will stated that it's included in the program. So my question is, what is the when we teach about the harm reduction, what is the most important thing you think that could change or to open the mind of the audience or the students? Thank you.
So to kind of paraphrase, but just because I also had the same question in my mind through the presentations, and Chase mentioned it as well, in the students that go through the work that you're doing, there is some type of internalized stigma, some barrier, and there's a need for an ideological change rather than just a knowledge transfer when it comes to teaching harm reduction. And so it would be great to hear from you your experiences in getting that change to come about. And yeah, particularly in Indonesia's case, but we have the same issue working with policymakers throughout Southeast Asia. When there's a punitive environment, harm reduction is criminalized. How do we get them to see the light?
Okay, thank you very much for your questions. And the experience of the master in Barcelona, teaching about harm reduction. In our opinion, I think that when students start with their studies, I think there are a strong position in treatment or in harm reduction. Sometimes as a polarized opinion. I'm a student with my point of view is of treatment, or my point of view is about harm reduction. And when they start to learn about the different professionals that work every day in treatment or harm reduction, they start to include middle points on the extreme position that maybe they came back with that. Sorry, with my English, I will try to explain. I think that in harm reduction, this situation occurs, and in treatment too. So when they start to know people that work every day with people in the street, outreach teams, when they start to go to the services in the different conflictive of problematic places in Barcelona, they start to include another human point of view. In this case, it's not the other one that I put the etiqueta. I put the label of the drug user is the other. And they start sometimes a reflection about my own consumption of alcohol, tobacco, cannabis, what represents my drug consumption in my life, how can I reduce the harm associated to my consumption. And I think that start to doing a specialized for training, they start to think about these issues. I don't know if I answer your question with my. Thank you.
I really appreciate the question and the answer that was just provided. I really do believe in the power of peers and identifying champions. So we're highly selective about our students each year, and the previous year's students will interview them. And it's rare, but there is a responsibility of being a gatekeeper to some degree, because these are highly vulnerable people that we're giving students a privilege to be around and serve, right? So some folks are just not in the place that they're ready to treat folks with kindness. But I think also having the students there allows them to see someone else who's not completely baked in it like me. You know, it took me 5 years. I'm still learning and unlearning, right, harm reduction, and it was a very slow process, even as someone who used drugs. But I think identifying the champions and then also connecting them with lived experience. The first day out on outreach for our students is always been so profound, and they say something like this, like, I realize they're just people, you know, and like they choke on their words when they say, because they realize what they're saying. Like, that means I thought of this group of folks as subhuman before, right? And it's I think it's that, and identifying champions, and then like was said, it's motivational interviewing and finding alignment in values. Like my students, I can pretty much guarantee they want these folks to not die. That's a good starting place, right? And they'd like to see positive change in their life. So it's starting with those values and finding alignment in the way that we get there, and finding the practicality in it, and aligning those values. And people will start to see their own dissonance naturally, just like we do with the folks that we serve.
To accept harm reduction and see that that's a necessity.
Yes, thank you very much for the response by my colleagues. That requires high-level advocacy, especially through the civil society, because if the drug policy have no provision for harm reduction, it becomes difficult to practice any form of harm reduction. So there is the need to influence policy in such a way that it will be part of the drug policy. Fine, it is not an easy process, but at the same time, through advocacy, justifications for harm reduction, eventually, one will get there. Like in Nigeria, it was not easy. Like I said, the drug law still criminalizes drug use. Amending that law has not really been easy, but the policy document has recognized harm reduction. So which means we are more like halfway, because until the law is eventually amended, that is when some ideas and perception about harm reduction will gradually wear off. But again, it is not something that will wear off overnight. It will definitely take time. So first, I will encourage that through advocacy, collaboration, the civil society, and so on, can push for the amendment of the law to accommodate our have policy that will accommodate provisions for harm reduction. Thank you.
Thank you very much. I also just want to pick up something that Chase said and related to what you've mentioned now. We have to see where we can align the values of what we are aiming to achieve and what the policymakers are valuing themselves. Maybe it can be around cost saving, around the impact of public health, consequences of people contracting other communicable diseases, and that might be your argument if it's not about the kindness, the compassion, and the human rights. I'll get to you, Willie. We had this lady in the front. I think you're next, and then Trang, and then we'll come over here. Yes, Susan.
Hi, thank you. Good afternoon. Susan Garrett with the International Technology Transfer Center Network. I have kind of a two-part question. My first question is for Dr. Calvo, more clarifying. So your program, the students are required to complete 300 hours of experiential learning out in the community, which I think is great. How many of those hours are on harm reduction? And maybe you stated that and I missed it. So that's my first question. The second part is perhaps for you and also Chase. What I have found also as an educator and engaging students in that sort of experiential learning is having students return back to the classroom to share what some of their experiences have been out in the field, helps to shape some of those perceptions or former values that they might have carried with them. So I'm wondering if you incorporate that into some of your work, as having former students coming back and sharing and interacting with current students. Thank you.
Thank you very much for the question. The part of the harm reduction contents in the master is about 50 hours and 300 hours of the visiting services of the community, out of the services that I presented. And yes, it's common to discuss during the different lectures, and we have different spaces to discuss between the lectures and the teachers about the situations that they have during the visits of the services. So yes, we have these spaces and are very interesting spaces to discuss. Yes, thank you.
I'd like to briefly say we have a weekly seminar that's 3 hours long where we connect theory and what they're learning in their other social work practicum, especially their clinical classes, with what we're doing. And then also in real time, folks come in waves. So one of my favorite things is at the beginning, modeling behavior and hyper-focusing on what I'm doing and being present, and then asking the students what they observed afterwards, if there's space between the next group of participants that come up, and really just analyze the interaction, you know, from a motivational interviewing perspective and otherwise, and then over time.
A prevention of any every type, okay? And then in the 50 hours is the compulsory training for all students. Then in the second year, there are voluntary, say, modules or seminars they can choose or not, okay? Then I would say all the students will choose case management, family therapy, group therapy, okay? Not all of them will choose harm reduction. It is about 70 to 80% will choose harm reduction, whilst others will choose a specific work at prison or family prevention or and others. And about how to change minds, we favor the participation. We have as teachers, as invited teachers, some active drug users participating in drug users associations. For instance, patients in methadone are sometimes associated. Okay, so they are invited to come and to share their experience as active drug users. In this case, usually methadone, sometimes other things. So in this way, I think the students look a little bit more the human being behind the stereotype. Because if confronted with the stereotype, you apply exclusion. Confronted with someone you know and you can appreciate, you apply inclusion and maybe understanding. That's thanks.
Well, it's more some remarks. Okay. Okay. Well, one, I think, and it's all correct what you have been saying, right? Human rights, the individual. But all people that don't know anything about drug use, they don't care, right? I mean, say like in Myanmar, we have all harm reduction in the National AIDS program, even in the National TB program. And as you all know, Myanmar is definitely a beacon of light in the universe for human rights, no? So I think what is not said is we are very, very pragmatic. We are basically, and I'm going to use stigma, but we are basically salesmen of junkies. That is what we are. And if we talk with people, they're only interested in their own personal interest. That means I don't even like to use the word harm reduction sometimes. Yeah? Because none of my staff, though we run the biggest program, was, for instance, invited by the Colombo DAP, dumbest addiction program, because we have the word harm reduction in our name. Yeah? I'll give you a few examples. If I go start methadone, right? I'm in the community, and I'm very sorry, this is all like a walk thing, right, that you talk about. People here in Southeast Asia are not interested in that. You have to get to the point what is cheap, yeah, and what is your interest. If we start methadone, they all said, and especially in Kachin, because a lot of these things are also linked to faith. And there, the Kachin Baptist Church makes very clear, oh, methadone is another drug, and it's another drug from the government to kill off our youth. Yeah? And then I go in and said, I don't care, you want it or not? If you want it, they come once a day in the morning. They will not steal all these kind of things. Or you just keep them and you go 3 times a day to the shooting gallery, try to get the money, and running more risk. Now, what you choose as a community, I never use the word harm reduction. And I think that is not clear. And I have another remark. It was all about opioids, right? And even in harm reduction conference, I often said a lot of people working in harm reduction should get their head out of their ass, because they only work with opioids because we have methadone, we have buprenorphine, right? But polydrug use is the norm. I didn't hear that. Where is the methamphetamine? Where are the tweakers that you definitely also will have in South Carolina, right? North Carolina, right? I mean, yeah, we have all these kind of things. And sometimes also as harm reduction, you have to push the agenda. Sometimes you do outlaw programming, yeah? I mean, if I read the guideline, for instance, UNODC, and that's not personal, right? For overdose prevention, yeah, try to get them to the DIC. No, no, no. I went everywhere and I gave all the drug dealers on the shooting galleries naloxone, and we trained their staff, right? And now 3 years later, even in Myanmar, yeah, now we can all do it. Yeah, I used peers to inject. They even went so far, okay, we will inject intravenously because they're so practiced they didn't even do it subcutaneously. So this is all pragmatic, it's cheap, and don't think that you talk all human rights and this and that, and it's gonna work. You always have the attitude against you, and in many countries also fate. And maybe we move a little bit more in Europe because it's the most secular environment you can currently get.
Thank you very much, Willie, and also for giving us the context on it's not so easy in all regions of the world to even talk about and approach harm reduction. I think very Camille knows in Indonesia. But still, we persevere. I also think from what you've mentioned, the value, and also it was reflected in Chase's program of peer outreach in reaching actually the people who use drugs. That's the essential component actually of harm reduction. At the same time, we have to get governments on board. And this is a consistent challenge, one which I think starting with educating the workforce, the health workforce, addiction workforce, and advocating on the policy level there that Martin has done, Agwogie in Nigeria, is also a component, an essential component of changing people's minds in a more systematic and systemic way. Time is up for our session. I acknowledge that. So I want to ask the people that I mentioned, Trang and the gentleman at the back, do you still want to ask your question?
Yes.
Okay, Trang, definitely. But before we get to that, I will also allow people, if you have meetings or if you do want to leave, please don't feel bad. I know that we've gone over time. You may leave, so don't hesitate to do that, because I also try to keep to time management, but sometimes the conversation is just so interesting. So is it okay if we stay a little bit longer? Okay, thank you.
Okay, now I feel really bad.
No, go ahead. Please, don't feel bad. We want to hear about Vietnam.
Yeah, so hi, I'm Trang, I'm from Vietnam. I work for a local NGO in Vietnam. And the topic today that you are presenting really resonate with what I do. I do both harm reduction and I also work on addiction treatments. We are establishing the models of community-based addiction treatments with the local governments as an alternative for the compulsory detention centers in Vietnam. So what we do a lot is provide trainings for who we call not professionals, but they are the only one who are going to provide the addiction counselings and addiction services for people who are addicted in the communities. And what we do for them is, the first level that we do is sensitize them that cognitive approach is not the only way that you treat people who use drugs or addicted to drugs. What you do to them is supporting them to help them to go to rehabilitation, but in a voluntary mindset. So what we do is, the first one is to shift the compulsory mindset to the voluntary mindset, and that is the first step that we do. What you are discussing today is integrating harm reductions to the work that we have been doing, and I think that is really a next step that we need to adapt. And what we have faced a lot of challenges during the work that we do is that no one believes in harm reduction in addiction treatment, because the purpose of people going to addiction treatment, we all know, is for abstinence, and people go to great length to punish people into the abstinence until they get to abstinence, let alone allowing people to access to harm reductions while they are on an addiction treatment program. So my question is that when you are developing the training program, you are aiming at the student in the institutions, but have you ever developed a program that specifically target people who are working on the field on addiction that integrates the component of harm reduction in it? That is my first one. My second... Yep. Okay, I'll stop at there. Thank you.
Yeah, in North Carolina, we've really had to focus on things practical, and not just in public health departments, but in hospitals. The law enforcement agencies are actually the reason that syringe services were legalized in North Carolina, because from a practical standpoint, we told them they're less likely to get stuck accidentally by a syringe. And a very conservative General Assembly in North Carolina was able to legalize it. So again, it goes back to that value alignment and identifying champions within systems. So in that public health department, there's likely a lot of people who use drugs, probably not openly, but there is someone who has a family member who uses drugs or lost someone. So identifying that person and letting them be the champion amongst their peers, because just like people who use drugs listen to other people who use drugs, cops listen to cops, healthcare workers listen to healthcare workers, doctors don't listen to anyone. Doctors listen to other doctors. So a lot of effort, and then again, like I said, I know people who have chosen to die rather than go to the hospital to get very simple IV antibiotics because of how they are treated in the hospital. So it's very important that we spend time there educating and helping them understand and telling stories like that, and also allowing people who use drugs to tell their own stories. I'm guilty of it all the time. As someone who formerly uses drugs, I'm not as impacted anymore, but we talk about this as doing on to people and not people doing for themselves, having autonomy, which is what this is all about. And like, I can't look at, I don't know who uses drugs or who doesn't in this room. Right? But like, I don't imagine there's a lot of people we're talking about serving here. So it's like we're in these rooms talking about people who are not here. So making sure that they have a seat at the table and can tell their own stories, because it's been said a lot here. It's really hard to hate up close.
Thanks, Chase.
I will be short. No questions, just one addition to Matej Košir from UTRIP, Slovenia. I was lucky to be part of the study visit in Barcelona of harm reduction, I would say, system. Because, you know, maybe it's normal for you, but I was really fascinated at that time that harm reduction interventions are integrated in the public health system. So usually we have very different perspectives and perceptions or realities about harm reduction, and usually in our countries those set of interventions are separated or isolated from all other interventions, like from treatment, recovery, etc. But what fascinated me in Barcelona, in Catalonia, that this system is integrated. And there is a collaboration between public health agency and civil society organizations. So I think this is the way to go in the future, to integrate harm reduction into the public health system. And that might work also with some countries which resist to implement harm reduction interventions. So, no questions.
Thank you very much for that very positive and uplifting ending remark. I would like to thank so much Fran Calvo, Chase Holleman, and Martin Agwogie for your time and your presentations, and of course to everybody for your questions. Session is concluded.